Hello and welcome to this 1 hour discussion of metabolic health and heart attack prevention. I am an interventional cardiologist who spends a lot of time putting stents in blocked arteries in patients having heart attacks, and my hope is that with this information we can prevent you from going down this path, or if you have had a heart attack or stent or bypass, prevent you from having another one. I do have to point out that this program is meant for my patients under my care, and if you do want to try this program, please check with your primary care doctor to make sure that it is safe and applicable to you, particularly if you are a diabetic taking diabetic medications. This diagram demonstrates the central concept of this talk, which is to show how obesity, overweight can lead to insulin resistance, and how insulin resistance perpetuates further weight gain and obesity, and how breaking this vicious circle is a very important pathway to reducing your overall cardiovascular risk. So here is an example of why even the average American is at risk of heart attack. Our patient is a 59-year-old woman who recently had her normal annual physical exam with her primary care provider, and at the time was told that her blood pressure is slightly elevated and she's about 20 pounds overweight, and she was told to eat better, eat less, and exercise more. About a month later, she wakes up at 2 o'clock in the morning with crushing chest pain and goes from being quietly asleep 1 minute to being in the cath lab about an hour later, undergoing an emergent procedure to open up a blocked artery. So this is what we found in the cath lab. On the left-hand side, where the yellow arrow is pointing, we can see there's an abrupt cutoff in the blood flow in the artery that feeds the front of the heart, and this is from a ruptured plaque that closed off the artery. And on the right side of the screen is what it should look like and what it does look like after inserting a stent. Now, it's important to understand what actually happens inside the artery at the time of the heart attack. This slide demonstrates a histological cross-section of the coronary artery in the minutes and hours before the heart attack. On the screen left, the purple ring demonstrates the outer confines of the artery. The blue-green area is the actual wall of the artery, and the middle white area is what's called the lumen, or the opening in the artery where the blood flows. On the right, there's just a magnification of this. Now, the area labeled NC is a cholesterol pool that's developed in the wall of the artery and has most likely been there for weeks and months, and typically was not causing any problems prior to the event because it's not narrowing the area where blood flows in the artery. In other words, this patient may have been able to run up a flight of stairs with no symptoms because there's no limitation of blood flow to the artery. But then at some point there's some instability that forms in that thin cap that covers the cholesterol, and an area of erosion or a rupture forms in that area, and the cholesterol contents leaks out, touches the blood, and immediately forms a blood clot that cuts off blood supply and leads to the heart attack. So in the 1940s and 1950s, as it became clear that cholesterol played a major role in these plaques that go on to cause heart attacks, it seemed obvious that the fat and cholesterol in the fat, particularly animal fat that we eat, leads us to become fat and to cause the cholesterol in the artery wall. Now, this argument appeared logical. It appeared a nice, simple explanation, but unfortunately, it was wrong. Now, this is not to minimize the role of cholesterol in heart attacks. It is unequivocal that cholesterol is a major risk factor and integral component of the plaques in the coronary arteries that lead to heart attacks. But the cholesterol in the plaques is not necessarily the same cholesterol in our diet, and I'll be spending quite a bit of time discussing that. This slide hints that there's something else going on in the average heart attack patient's lipid profile beyond an abnormal elevation in the LDL or bad cholesterol. This is from a study of over 160,000 heart attack patients comparing their lipid profiles to the average American that does not have known heart disease. And as you can tell, the LDL or bad cholesterol is actually slightly lower than the average US person without heart disease. What's abnormal is that in these patients, the triglycerides or blood fats are abnormally elevated, and the HDL or good cholesterol is lower than the average US person. And this hints at a significant underlying metabolic disturbance, which is going to be really the crux of this talk, and that is the metabolic syndrome, which is a major risk factor for developing heart disease. Now, just because the hallmark lipid abnormality in the metabolic syndrome is abnormally low HDL and elevated triglycerides, this does not mean that we can ignore the LDL just because the levels are fairly average. The LDL in LDL cholesterol stands for low density lipoprotein, and these are the protein particles that actually carry the bulk of cholesterol around in the bloodstream. When we talk about LDL cholesterol, we're actually measuring the amount of cholesterol carried within these particles. And in these two theoretical patients here, one with metabolic syndrome and one metabolically healthy, the amount of cholesterol carried in these particles is identical at 130. However, in our metabolic syndrome patient, this cholesterol is carried in many small LDL particles, whereas in the metabolically healthy patient, the same amount of cholesterol is carried in fewer, larger particles. It appears that the smaller particles find it easier to get into the wall of the coronary artery and establish the atherosclerotic plaque. The metabolic syndrome is a clinical entity that usually includes most of the following features. There is an increased waist circumference, which reflects increased belly fat or visceral fat. The blood sugar is either elevated or at the upper end of the normal range. Blood pressure is usually somewhat elevated, and the lipid profile is fairly characteristic with predominantly low HDL and high triglycerides, which gives you a triglyceride to HDL ratio usually 3 or higher. Metabolic syndrome sits on a spectrum that includes pre-diabetes and type 2 diabetes mellitus, and can almost be considered pre-diabetes. A patient with metabolic syndrome has a 5 times higher risk of eventually developing diabetes mellitus. What these syndromes have in common is this concept of insulin resistance, and this currently affects more than 150 million Americans. This concept of insulin resistance is not only important in cardiac disease, but is a major risk factor for stroke, cancers, and even Alzheimer's. So before diving into the concept of insulin resistance, it is important to understand the role that insulin plays in energy homeostasis in the body, and particularly its role as a hormone of energy storage. If you consider the last couple of 100,000 years of man's time on Earth, one of our biggest threats has been starvation. So our bodies became brutally efficient at storing away every calorie we consume and not to waste any calories. So if you consider a 3,000 calorie day, there are 2 storage compartments where we can store those calories that are consumed. The first is the liver, which can store about 2,500 calories, or again about a day's worth of calories. And then the fat stores can be endless. We can store hundreds of thousands of calories in fat, and we can keep adding. The more we eat, we can add more fat stores. And the reason I depict the liver as a fridge is that it has, number one, limited capacity, but also it's easy to get food in and get out. And that's what we live on during the night when we're not eating. Our bodies consume the glycogen stores in our liver. The fat stores are more longer term and much harder to actually get the energy back out of that. And that's going to be the focus of quite a few upcoming slides, and one of the reasons why it's so difficult to lose weight. The amount of insulin our pancreas releases after a meal depends very much on the macronutrient content of that meal. So with a carbohydrate meal, and particularly sugar or very refined carbohydrates, we get a very early and high peak in insulin release. With protein, it's quite a bit less, and with fat, it's a very low and blunted response with really minimal insulin released. So here we're sitting down to a meal, and we need insulin to take the excess calories in that meal and store that in liver and fat. So what you see on the graph is a insulin spike that occurs following the meal, and because that meal is digested and absorbed over a period of 2 or 3 hours, that insulin release will peak and abate over about 2 or 3 hours. So imagine now we have 3 meals a day. Each one of those meals will generate a spike that again is dependent on the macronutrient content, but each spike will last about 2 or 3 hours and will give us an insulin exposure as depicted in that graph. Now imagine we have not only 3 meals a day, but we are snacking constantly in between. Now we need a constant high level of insulin to keep driving this excess calories into storage. And because our refrigerator is getting full, we need even a higher baseline level of insulin to keep driving this into this overstuffed refrigerator. So you're starting to see the concept of insulin resistance emerging. Because of being full, the refrigerator is resistant to further filling and requires higher and constantly elevated levels of insulin for this. This is such an important concept. We're going to look at insulin resistance in another way. In this patient with normal insulin sensitivity, the cells on the right, those yellow boxes, have just a little bit of sugar in them. That's the red. And because the cells don't have a lot of sugar in them, it is fairly easy to get the sugar that's absorbed from a meal in the blood into these cells. And you only need a little bit of insulin because the patient is insulin sensitive. So that is depicted by easily pouring water into a glass from a jug. Just a little bit of insulin, a little bit of force is needed to drive the blood sugar into the cells. In this patient who is more insulin resistant, the cells have more sugar in them, and because of that, a more powerful force is needed to drive the blood sugar derived from a meal into the cells, again because the cells already have quite a bit of sugar in them. So in this case, the insulin level required is increased, and that's depicted by now needing a water hose instead of just gently pouring water from a jug into a glass. Now this patient who has established type 2 diabetes mellitus is very insulin resistant, and the cells are full of sugar, and because of this, the driving force needed to drive blood sugar into the cells now needs to be a lot higher. So now we need a fire hose, in other words, a very high insulin level to drive the sugar from the diet into the cells. But you can see in this patient, even that high insulin level is not enough to empty the blood sugar from the blood. And at this point, the blood sugar now starts increasing. And this now is poorly controlled diabetes. So what most patients and physicians know and focus on is that in patients who are diabetic, they have a high blood sugar, and we can measure this. But what's often ignored and is equally, if not more important, is that these patients also have a high insulin level. which poses additional long-term danger above and beyond having a chronically elevated blood sugar. And that's what the rest of this talk is going to focus on, how to get this chronically high insulin down to more normal levels. And broadly speaking, there's two ways to do this. One is to cut back on the frequency of meals. So instead of having 3 peaks like you have on the left, you just have 1 peak on the right, for example, if you just had dinner. And the other very important way that we're going to focus on is improving your insulin sensitivity so that your baseline insulin level is lower. And again, we'll spend quite a bit of time discussing this. So at this point, you may wonder, my doctor keeps talking about high blood sugar. Why do you keep talking about high insulin level, and why is that important? Well, it is important in at least 2 different ways that I will explain in the next few slides. Firstly, excessive levels of insulin can have direct negative effects on cells in a variety of different organs. And secondly, chronically elevated levels of insulin directly prevent you from being able to burn fat and therefore lose weight. To be clear, I'm by no means minimizing the importance of correcting a high blood sugar. There's no doubt that a chronically elevated blood sugar will lead to what we call microvascular complications, which affect the small blood vessels in the eye, causing what's called retinopathy, in the kidney, nephropathy, and in the nerves, diabetic neuropathy. That is very clear and undisputed. And by improving blood sugar control, you can prevent or delay these complications. However, chronically high insulin levels clearly contribute and may be a main factor in the development of coronary artery disease, as a risk factor for stroke, cancer, and even Alzheimer's. And it's important to realize that improving blood sugar by itself may not impact, and usually does not impact, the insulin level, and in fact may increase the insulin level. For example, giving exogenous insulin as an injection when blood sugar control is inadequate on oral agents. The danger here is that if we wait for the blood sugar to become abnormal, in other words, someone to be diagnosed with pre-diabetes or diabetes, it was already really quite late in the game, and the insulin levels have been high for 8 to 10 years already, with already some degree of damage to the cells and organs. The elevated glucose is therefore just the tip of the iceberg, with the actual iceberg being years of elevated insulin levels. Now, this may actually be the most important slide in this entire talk. We talked about how insulin is a hormone of storage. In other words, it's the hormone responsible for taking extra calories that we consume and putting that into storage. It therefore only makes sense that insulin wants to protect those stores. So if you have insulin in your bloodstream following a meal, you cannot burn fat. Insulin prevents you from accessing and burning fat stores. And that is part of the reason why, if you take a significantly calorie-reduced diet where you consume only, say, 1,500 calories a day, but you consume that as frequent small meals, you will still not lose weight, because those small meals still generate an insulin response throughout the day, and that insulin prevents you from burning fat. So we've now established that a chronically high insulin level is bad for your health long term, and that patients with insulin resistance have chronically elevated insulin levels. So how do you know if you're insulin resistant? Before we get into any fancy blood testing, a simple way to detect this, unfortunately, is the presence of being overweight or obese. But not just any kind of obesity. It's really the excess belly fat or visceral fat that's a marker of insulin resistance. In a man, if you have a waist circumference or belt size more than 40 inches, and in a woman 35 inches, you likely have excess visceral fat, and there's a high chance you have some degree of insulin resistance. Unfortunately, the problem of insulin resistance we get from having excess visceral fat is only half the story. For many years, fat cells were thought to be just inert storage areas for energy, but we now know that these cells are very active metabolically and secrete chemical mediators that are very important in oxidation and inflammation, two processes that are integral in the formation of plaque, and these plaques then becoming unstable, leading to heart attack and stroke. So to recap, visceral fat or excess fat around our abdominal organs is not only cosmetically annoying, but is in and of itself a functional independent organ that leads to insulin resistance and also the production of a variety of chemical mediators that directly contribute to our risk of heart attack and stroke. A very common misconception is that it is excess dietary fat that leads to this visceral fat around the organs that leads to insulin resistance, but actually it is excess sugar intake and specifically excess fructose intake that is a risk factor for developing visceral fat. Just to cover some sugar basics, we get most of our sugar from sucrose, which is table sugar and comes from either cane sugar or beet sugar, and then artificial high fructose corn syrup. On the left there, the sucrose or table sugar is a molecule that's made up half out of glucose and half out of fructose. Now, glucose is considered a universal fuel. It's a good fuel because all cell life, including bacteria, plants, animals, including humans, can burn glucose as a very efficient fuel. Fructose, on the other hand, humans have a very limited ability not to burn as fuel, but to convert into glucose. High fructose corn syrup is slightly higher fructose concentration, 55%, but in the soda you find in the movie theater, that's actually very high concentrated high fructose corn syrup that contains 65% fructose and 35% glucose. Now, just to repeat that point, which is very important, human cells cannot burn fructose as a fuel, but we can convert it into glucose, which we can burn, but we have a very limited ability to do that. Only about 20 grams a day of fructose. Anything more than that, we overwhelm the liver's ability to metabolize it into glucose, and the additional fructose we take in above this threshold, that's what gets converted into visceral fat. To reverse this dangerous syndrome of insulin resistance, we have to target the visceral fat. So how are we doing in this battle against obesity? Well, it turns out not so good. This map here from the 1990s shows the US obesity rates by state, and you can see that Mississippi was the most obese state at this time, with about 25% of the population obese, and Colorado was quite lean with fewer than 10% of the population obese. If we now fast forward 30 years to today, you can see that Mississippi has now increased to where more than 55% of the population is obese, and Colorado, which 30 years prior had less than 10% obesity rates, now have rates of about 30%, which is more than Mississippi had 30 years prior. Unfortunately, this epidemic of obesity dates back to the 1950s, when this man, Ancel Keys, came up with the fat hypothesis, which attributed dietary fat as the main culprit for not just our obesity, but for the increasing incidence of coronary artery disease and heart attack. He postulated at the time a concept that seems common sense and intuitive, but unfortunately to date has still not been proven definitively with any scientific study. He proposed that the dietary fat that we obtain from animals and the dietary cholesterol from the same source is responsible for our obesity and also is directly responsible for the cholesterol buildup in the wall of the coronary arteries that subsequently leads to heart attacks. That something was wrong with this theory is clearly illustrated with this graph that shows that when the low-fat recommendation was introduced in the late 1950s, we subsequently increased our obesity rates from 10 to 12% to the high 30% in the span of about 40 to 50 years. So how on earth can a low-fat diet lead to an obesity epidemic? Well, if you cut back on your fat intake, you cannot substitute protein in that space because of the limited ability we have to digest a high protein diet, and therefore the gap was filled by a high carbohydrate intake and particularly sugar and refined carbs. This food pyramid is likely one of the biggest disasters in public health in the last few generations, and this led to carbohydrate intake in excess of 55 to 60%, and arguably is the biggest culprit in our current epidemic of obesity. Fortunately, this food pyramid has since been abandoned. Just a brief reminder, all the food we ingest can be broadly categorized into proteins, carbohydrates, or fat. Unfortunately, the term carbohydrates is just too wide and includes both a chocolate-covered donut as well as a piece of broccoli. A good way to think of carbohydrates is to divide them into what's fast carbs or slow carbs, and this refers to the speed with which the carbohydrate is broken down into glucose and then subsequently absorbed. On the one hand, a donut or a slice of white bread is broken down really fast into glucose and also very rapidly absorbed, partly because it doesn't contain much fiber. On the other hand, a complex carbohydrate like a piece of broccoli or cauliflower takes quite a bit longer to be digested into glucose, and the absorption is even further delayed because of the fiber that's in these natural carbohydrates. The reason the speed of conversion to glucose and the rate of absorption is so important is that this determines the insulin response, and remember, it's all about keeping the area under the curve of insulin as low as possible. Fast carbs are rarely found in nature, as even the sweetest fruit has a lot of fiber in it, which slows down this process of breakdown to glucose and absorption. We have artificially created this category of fast carbs, and we have done that through heavy processing of pretty much all grains, including wheat, corn, and even oats. All grains consist of three compartments. The first being the germ in the center of the grain, which contains protein, lipids, and some micronutrients. Then there's the endosperm, which is the largest portion, which is the starch. And then the outer shell, which is bran and very rich in fiber and vitamins. With processing, the germ and bran is excluded, and only the endosperm is used to create starch. This completely changes the nature of the carbohydrate, because the bran, which would normally slow down digestion, is removed, and only the easily digested endosperm or starch remains. The story unfortunately only gets worse. The dough, even though it is a massive supply of rapidly absorbed glucose, by itself is quite tasteless, but serves as the perfect carrier to add on sugar, salt, as well as fat. You only have to think about cakes, donuts, and pizza, to see how this large, rapidly absorbed, fast, starchy carb is the perfect carrier for a combination of fats and sugars. This slide makes it very obvious that our obesity epidemic is related to sugar intake. Back in the mid-19th century, sugar was really only available from either cane sugar or beet sugar, and was really quite expensive as high fructose corn syrup had not been invented yet. Because of this, the average consumption of sugar in the mid-19th century was only about 2 pounds of sugar per year. This rapidly increased to about 20 pounds of sugar per year in the 1920s, and in this past decade that has increased to where the average American now consumes 140 pounds of sugar per year. This slide shows how the weight of an average 18-year-old male has increased over this period of time and clearly is related to our intake of sugar. Over this same period of time, our intake of fat and protein is actually decreased, so clearly we cannot blame excess fat intake as a cause of the obesity epidemic. So there are three fundamental problems with our modern diet. Number one, excess sugar. The excess sugar that our liver cannot metabolize gets converted into fat, and this gets packed around our organs as visceral fat, which directly leads to insulin resistance. Number two, we eat way too much refined carbohydrates, for example, bread. This leads to a rapid high insulin spike compared to, for example, a more complex carbohydrate like a piece of broccoli. And number three, we eat too often, which leads to a persistently elevated level of insulin, and we do not allow this level to drift back to its baseline. So to summarize, the problem is we eat too much of the wrong food too often, and the rest of this talk will address how we fix this. I'm not going to spend too much time on this slide because I think everyone's pretty aware that this paradigm does not work. Eat less, exercise more has been with us for decades and does not work. Now, I'd like you going forward to focus on these three critical points in a weight loss reduction program. We already discussed the importance of bringing our insulin levels down because we cannot burn our fat stores if we have insulin in our bloodstream. So cutting out sugars and limiting refined carbs is critically important to bringing insulin levels down and again allowing us to access fat stores. The third point there is what we'll be spending the rest of this talk on, and that is time-restricted feeding or intermittent fasting, a very powerful concept and a very effective tool in both weight loss and improving insulin sensitivity. Now, I have to re-emphasize this point. Exercise is an incredibly important tool in promoting overall cardiovascular health. That is indisputable. But unfortunately, exercise is not a very effective weight loss tool, and there's many different reasons for that. But one of them is that simply exercise makes you hungry, and study after study has shown that increasing exercise increases hunger, which leads to increased food intake. Having said that, there is a lot of evidence that exercise increases insulin sensitivity, so it definitely plays a supporting role alongside reducing carbohydrate intake and time-restricted feeding in a weight loss program. So let's look how intermittent fasting or time-restricted feeding could potentially help us burn fat and thereby lose weight. This graph shows our insulin levels as it varies after meals over a 24-hour period starting late evening. As we go to bed, our insulin level is still elevated following dinner and maybe a bedtime snack. But as the night progresses while we sleep, our insulin level gradually drops since we're not eating any new food and nutrient that would stimulate insulin release. Now, right about breakfast time, our insulin level is getting close to that red dashed line, which signifies the level of insulin which prevents us from burning fat. So if we can get our insulin level below this level, theoretically we're in a position where we can start burning fat. Remember, a certain level of insulin in the blood limits the ability to burn fat, and we need to try and get our insulin level below that level. Now, just as we're approaching this level, we have breakfast that typically includes carbohydrate and possibly sugar, and that causes an immediate spike in the insulin level, which again will last for 2 or 3 hours, and often with a snack late morning, followed by lunch, followed by a snack, followed by dinner. So you can see our insulin level stays elevated throughout the day, and unfortunately stays above that threshold level that enables us to burn fat. So we can go this entire day without being able to burn fat because of an insulin level that's elevated. This slide will show why just eating less does not necessarily allow us to burn fat and thereby lose weight. Here we're still eating 3 meals a day, but they're significantly caloric restricted, maybe 400 calories per meal, which gives you 1200 calories a day, which is a severe caloric restriction. However, despite this being a severely caloric restricted diet, these 3 meals still generate enough of an insulin spike that it keeps us above that fat burning threshold all day long. This also demonstrates why most people on a severely caloric restricted diet feel really miserable, because although these 3 small meals generate enough of an insulin response to limit us from being able to burn fat, it doesn't supply the body with enough calories for normal bodily functions, and therefore our core temperature drops, a lot of our physiological processes slow down, and we feel tired and fatigued and lethargic. The body would actually like to be able to burn fat because fat is a preferred fuel, but again, because of the insulin response generated by these smaller meals, we cannot access our fat stores. So let's see what happens if we extend our natural overnight fast a little bit longer up to noon. So again, on the left-hand side of the graph, our insulin level peaks late evening after dinner and after snack. It again progressively drops to the lowest level right before breakfast. But instead of eating breakfast, we're going to push our first meal out to lunchtime. This way, our insulin level is actually going to stay below that fat burning threshold for 4 to 5 hours until we have our first meal at lunch. So that entire morning now, because your body is deprived of new calories, you're actually allowing your body to burn your fat stores because it's not being inhibited by an elevated insulin level. Now, the most common reaction at this point is to think, that won't work for me. I'm going to go crazy with hunger by mid-morning. In fact, the exact opposite is the truth. The late morning hunger we experience that often leads to snacking is usually because of a high carbohydrate breakfast that we ate that morning. And there are 2 physiological pathways that lead to this increased late morning hunger. When we do have a high carb breakfast, we get this expected big insulin spike, which often overshoots and lowers the blood sugar too much, and it is that relative hypoglycemia that triggers the hunger signal in the brain. The second mechanism is a little bit more complicated. In our fat cells, we secrete a hormone called leptin that basically tells the brain, look, there's plenty fat stores and therefore energy available, you don't have to eat. The insulin that's released following breakfast actually inhibits the signal. It therefore actually hides the signal from our fat stores that tells the brain that it doesn't have to initiate appetite and an eating sequence, and therefore makes us hungry. This slide summarizes the two mechanisms by which intermittent fasting or time-restricted feeding will lower the overall insulin level. The first mechanism we alluded to earlier, and it's fairly obvious: the fewer meals you eat, the fewer insulin spikes you have, and considering that each of these insulin spikes can last 2 or 3 hours, just reducing the number of those spikes will reduce the amount of insulin under the curve. With the second mechanism, remember that we discussed earlier that insulin resistance is proportional to the amount of visceral fat that you have around your organs, and particularly around your liver and pancreas, and that as we lose weight and burn this visceral fat with successful intermittent fasting, we will get more insulin sensitive as you lose this visceral fat, which means that the absolute level of insulin for any particular function gets lower and lower as our muscles and liver require less insulin to drive sugar into storage. So before we discuss different intermittent fasting strategies, let's look at what the average American diet is and what the average American does. And I would call that an 8-16 fast, which means we typically have breakfast anywhere between 6 and 8 a.m. Often there's a small mid-morning snack around 10. We have lunch 12 to 1, late afternoon snack around 4, dinner 6 or 7 p.m., and then often a bedtime snack at 9 or 10 p.m. So our normal natural fasting period is really only from about 10 p.m. to 6 a.m., so about 8 hours of not eating. And as we described earlier, that amount of time is just not enough for the insulin level to drop below the threshold where it allows you to burn fat. Now, this is not an exaggeration. Studies have shown that the average American eats 5 meals a day if you do include these snacks. And this shows you why on the average American diet, there is no period of time where our insulin level drops low enough for us to burn fat, which is why the typical scenario is gradual weight gain every year, year after year, and why any diet regimen based on this framework is really doomed to fail. So what we want to do is change that from an 8-16 fast to a 16-8, which means we double the duration of fasting, and we limit our eating window from 12 noon to 8 p.m., which means you skip breakfast, so your first meal of the day is going to be at noon. It's okay to do healthy snacks for the rest of the afternoon, have dinner, and then be done at 8 p.m. So again, your eating window is between 12 noon and 8 p.m., and you're fasting from 8 p.m. until 12 the next morning. Now, it is important to realize that even a healthy snack taken during the fasting window, for example, if you have a half an apple in the morning, that defeats the purpose, because even though this may be a healthy snack, an apple, a piece of fruit, some yogurt, it does contain sugar and will therefore elicit an insulin spike, which again will shut down the ability of your body to burn fat. So even a small amount of a healthy snack defeats the purpose. Now, as you get used to this 16-8 fasting regimen, and believe me, you will, it is a lot easier than it sounds, you may want to start pushing this out even further on 1 or 2 days a week, which means limiting your eating window between 4 p.m. and 8 p.m. In other words, you're moving to a 24 fasting eating regimen. This is very effective because if you think about it, it actually doubles the amount of time that your body has to burn fat. Because on a regular 16-8 fasting protocol, you're probably only burning fat the last 4 hours of that. In other words, between, say, 8 a.m. and noon, because remember, your body takes time to deplete the glycogen stores during the overnight fast, and it really only starts burning fat probably about 8 a.m. So by extending your fast to 4 p.m., you are doubling the time from 8 a.m. to noon to 8 a.m. to 4 p.m. Also, there's really no hard and fast rules, and there's a lot of potential flexibility. For example, you may decide to do 20-hour fast twice a week and do 16-hour fast the other 5 days. And it's also okay to cheat on special days. You may find that you'd like to have breakfast and lunch with your families on Sundays, so Sundays may be a regular day for you. The key, though, is to have most days of the week that you follow a specific fasting protocol. Now you will receive another link to a presentation by one of our physician assistants who's also a registered dietitian regarding specific food ideas and more details regarding specific foods. But let's just review the 10 most important general ideas as you embark on this low carb, low sugar, and intermittent fasting nutrition plan. So point number one may seem obvious, stop eating when you're full. But if you think about a buffet, we typically want to get our money's worth going to a buffet, so it's natural to want to eat more and continue eating even when you're full. So buffets are probably not the best ideas. Another idea linked to this is never to go to a restaurant when you're really hungry, because that's when you get into eating that basket of bread before your main meal. So a handful of nuts, for example, before going to a restaurant is probably not a bad idea. We discussed starting with a 16-8 intermittent fasting protocol, and again, you don't have to do this every single day. If you want to start by doing it 5 days a week, and for example choosing 2 special days where you don't do it, and that may well be your weekend days when you want to have breakfast and lunch. Point number 3 is critically important. The average American now consumes over 70 grams of sugar a day, and remember that means half of that is fructose. So that's 35 grams of fructose. And as we discussed, our liver can maximize out at 20 grams of fructose metabolism a day before it converts that extra fructose into fat. So on a daily basis, all that extra sugar gets converted to fat. If you need a number, try and keep it under 20 to 25 grams of sugar a day, but also be vigilant as to where sugar hides out. For example, even store-bought bread contains fructose because it's a browning agent and it increases the shelf life of bread. So really, sugar lurks everywhere. Minimizing processed food and trying to eliminate fast food are also very important steps in this plan. Unfortunately, these foods are very rich in heavily processed carbohydrates as well as sugar and tend to be very low in fiber. And for this reason, we tend to not get full or satiated following a fast food meal, and we tend to overeat. It's much healthier to consume your carbs as vegetables and fruits, but you have to be a little careful of the tropical fruit like bananas that have a lot of sugar, and you can overdo that. As far as vegetables, cauliflower and broccoli have a lot of fiber, and you really cannot overeat on these vegetables. Point number 6, minimize bread, particularly white bread, as well as potatoes, as these are really very simple carbohydrates and get converted into glucose very quickly and easily and results in a significant insulin spike. The same applies to white rice, so substituting that for brown rice or quinoa is much better, as these are more complex carbohydrates and don't cause the same insulin spike. For your snack, nuts like almonds, pistachio, or walnuts consist mostly of healthy unsaturated fats and some protein with very little carb, and therefore generates much less of an insulin response than you would get if you snack on, for example, crackers or potato chips. As far as animal protein source, fatty fish, for example salmon, is preferred, but red meat once a week is also reasonable, and butter and cheese in moderation also a very acceptable part of this diet. And lastly, although the case against saturated fats has really been overblown, that is, fats that include animal fats like beef and pork, as well as butter and whole milk, although that has been overblown, it probably is still important to emphasize unsaturated fats in your diet over saturated fats. And examples of good unsaturated fats include, for example, fatty fish, avocados, olives, as well as nuts. Now, I only have one slide on exercise, and that is not to minimize its importance. As we discussed, it's not a great tool by itself for weight loss, but it remains very important for overall cardiovascular health, and it is important in optimizing your insulin sensitivity, which helps with the overall nutrition plan. Now, what I'm trying to show here is, unlike performance and amount of training in sport, which is linear, for example, the more tennis you play, the better you get, the cardiovascular health benefits with exercise is not linear. In other words, by walking briskly 15 minutes a day for 3 days a week, you may get up to 3/4 of the cardiovascular benefit with that exercise compared to someone who has a much more rigorous training program. Getting adequate sleep plays an incredibly important part of maintaining a healthy weight, and unfortunately, most of the things we've discussed so far won't work very well if you do not get adequate sleep. And adequate sleep is typically defined as getting 7 or more hours of sleep a night. It has been shown in many studies time and again that getting inadequate sleep leads to an increase in the hunger hormones, a decrease in the satiety hormones, and also affects our judgment as to what kind of foods we eat. This has been very well studied in experiments where patients are admitted into a sleep lab for a couple of weeks and then observing their eating patterns as you vary the amount of sleep they're allowed to get. After having inadequate sleep for about a week and then being exposed to a wide variety of food options for breakfast, it has been shown that patients tend to gravitate towards the comfort food type breakfast, and on average will eat 300 calories more per day in the week that they do not get adequate sleep. After then reversing this and giving them adequate sleep for about a week, they will reverse this trend, eat 300 calories a day less, and typically eat more healthy food for breakfast. The other important hormone that tends to be increased if we get inadequate sleep is cortisol, which is the body's stress hormone. And when this is elevated, we tend to burn muscle and preserve fat. Unfortunately, the majority of Americans are not getting an adequate 7 or 8 hours sleep a night, and some of this is unavoidable due to hectic job and home commitments, but there are a few things we can do to optimize the time that we do sleep. Try and avoid any caffeinated products after 1 or 2 p.m., and that includes sodas. Limit alcohol to 1 drink a day and try and get that drink in before 7 o'clock. Try and limit your screen time in the last hour before bed, and this includes not just TV but iPhones and iPads as well. Try and avoid the distraction of a TV in the bedroom, particularly a TV right before you go to bed. If you have the option, try and keep the room at a cooler temperature, which is better for initiating sleep. And lastly, but probably most importantly, if there is a chance that you have sleep apnea, this needs to be addressed, as sleep apnea results not only in inadequate amount of sleep but very poor quality sleep. Controlling stress is the 4th pillar to build the foundation for metabolic health. During periods of stress, our body's natural inclination is to protect our energy stores. Through a complex set of neurotransmitters and hormones, this leads to reward seeking, hunger, and with the increased food intake that accompanies this, It also leads to additional visceral fat formation. Unfortunately, chronic stress has become part of our modern lifestyle, and usually trying to remove the underlying stressful trigger is usually not possible. Fortunately, there are ways to deal with this quite effectively. Walking seems to have stress-reducing properties that goes beyond just exercise, and we probably all remember times when we can clear our head and just generally feel better after a walk, particularly in nature. Mindfulness, or sometimes called meditation light, is also an extremely effective way to reduce stress, and although I personally was skeptical of this for a long time, I'm now convinced that it is very effective and works for most people. And this can be done just a few minutes a day and anywhere, and there are numerous apps on your phone or computer that are free that really helps with this. So to summarize, there are 4 pillars needed to secure the foundation for metabolic health. Nutrition is arguably the most important of the 4 and includes the concept of low sugar, low carb, along with intermittent fasting or time-restricted feeding. Exercise plays an important supportive role to help with improving insulin sensitivity, as well as the other cardiovascular health benefits that go along with frequent exercise. Getting adequate sleep and reducing stress have often been left out of traditional diet and overall healthcare plans, but without these 2 components, you are unlikely to find success. Now, before we discuss how to use this information and implement a plan, we first have to discuss habits. We all have good habits and bad habits, but unfortunately, bad habits seem to dominate our diet. I want to at least touch on these 2 concepts of friction and reward. The concept of friction is probably most easily understood if you use an example like having a scoop or 2 of ice cream when you get home as a habit. If you open the freezer door and there's always a tub of ice cream there, that's low friction as far as continuing the habit. If you sometimes simply don't buy ice cream or you put it in the very back of the freezer, those things increase the friction or the effort you have to make to complete the habit and will help to try and break the habit. At the same time, you can decrease the friction towards developing good habits. For example, always having plenty of fresh fruit and vegetables around the house and having it in a prominent place in the refrigerator. Rewiring our reward system is somewhat trickier because our brains are wired to respond to sugar from a very young age with the release of dopamine, which gives the sensation of pleasure with that activity. Retraining the brain to rather respond to, for example, a handful of almonds is imminently possible, but it can take 1 to 2 months. 1% better refers to the concept of making small changes in many different habits that cumulatively can lead to a large positive outcome that improves the chance for success. Examples include using the stairs at work instead of the elevator, particularly if it's only 1 flight of stairs, skipping the candy in that candy jar you walk by on the way home from work, having an 8-ounce latte instead of a 12-ounce latte, and having full-fat cream in your coffee instead of sugar if you don't like it black. Another behavioral hack that can help you start good habits and break bad habits are visual cues. A cue is an automatic brain response to sensory input, and this can be visual, it can be auditory, or it can even be smell. We all know that the game is lost once you smell those freshly baked cookies. We already talked about opening the freezer door and seeing that tub of ice cream. That is a negative cue. An example of a positive cue would be leaving the dog leash next to your bed at night so that when you wake up in the morning, you see the leash, you think about taking the dog for a walk. Now, the next step is synthesizing all we've learned and creating an implementation plan. And critical to this is actually getting it on paper and putting it in a place where you will be seeing it every day. Now, this is just an example, and you will be creating your own plan customized to your own particular needs and wants. Under nutrition, for example, you may want to jot down the time of your first meal of the day, and you may start at 10 and then eventually progress to noon, and who knows, maybe end up at 4 p.m. as your first meal of the day if you want to pursue an aggressive 20-24 fasting regimen. And you may decide to do this 5 days a week to start off with. The next step is trying to omit your biggest vice from your diet. For example, you may have a cookie after lunch on a regular basis, or have a bag of potato chips with your lunch. You may decide to omit that from your lunch. The next step would be to take your next biggest vice and maybe just have the portion. Again, getting back to the ice cream, you may like 2 scoops of ice cream when you get back home after work at night. Maybe start cutting that in half to 1 scoop. You then do the same with exercise and commit to doing a certain amount of time of a certain exercise on certain days of the week. Again, all customizable according to your needs. You may enjoy using a Fitbit, so you may jot down the number of 1,000 steps per day you aim to take. And again, do the same with sleep. Commit to being in bed at a certain time every night, and you need to review this every night for compliance. This implementation plan is really critical for success and really needs to be written down and placed somewhere where you will review it every day until these new actions become habits after 1 or 2 months. Now, nothing is more rewarding or encouraging than seeing the objective changes happen as you implement this plan. If you choose to do so after watching this video, we can enroll you in our cardiometabolic clinic, where we do some objective measurements and blood testing at baseline and then again at 4 months to monitor progress. For the duration of the 4-month program, we have group question and answer sessions with spouses coming along, and also access to additional material. A detailed discussion of this blood work is a little beyond the scope of this talk, but essentially we demonstrate improvement in insulin sensitivity and also show that your cholesterol profile does not deteriorate on the low carb, higher fat diet, and in addition also show how your systemic inflammatory state improves with this program. To make these different lab values easier to understand, I have created here what I consider 5 typical metabolic profiles. The numbers don't necessarily reflect cutoff values to get into each category, but more represent typical values within each category. The far right column is an estimate of insulin resistance, which is calculated from simultaneous fasting glucose and insulin values. And generally, the smaller that number, the more insulin sensitive a patient is, and this can be easily monitored as you progress through the program. So thank you for watching, and please be sure to click the link below to watch the associated video that covers more practical tips on food substitution and other dietary advice to follow a low sugar, low carb diet. Thank you.